welcome to my video entitled ICU Training Cardiovascular System. My name is Manny Barbosa and I have been a nurse for 30 years and I am an ICU nurse educator. So the driver of this video is not to monitorize it, but it's more so of giving you that information if you ever looking for one, because I know being an ICU nurse, there's a constant change that we deal every day at work. And if your ICU doesn't have any nurse educator to follow up, to conceptualize, to provide educational materials for you, so you came to the right place. So what I normally do at my job is we train new nurses, seasoned nurses, nurses who are transitioned from med-surg to ICU. So everybody that will come to our organization, they get this training. Sometimes I feel like the 5 days didactic training is very short. So I try to supplement with some video materials. So this is for you. So normally when I discuss anatomy and physiology, I just don't read the slides because I really hate reading slides. But I use the analogy that how can I use this information at the bedside, right? So remember, your heart is, we call it like this, as the size of your closed fist. So when you look at it, they will measure here to here, and I look at the book and it's pretty much standard, you know. So when you try to measure here to here, it gives you 12 centimeters. And then to here, it's like 6 to 8 centimeters. So the width and the length, okay, so 6 by 12. And it's not really like facing like this. It tilted to the left like this. And the reason being is that just in case you get into an accident or your patient got into an accident and they hit the steering wheel, normally they will complain of chest pain, right? Either fracture of the ribs or the right ventricle. Again, take note, the right ventricle is the one who get hit first because it's tilted this way. But it's always okay. I don't really worry. When I was a new nurse, I worry. But then the cardiologist told me, no, don't worry, because the right ventricle is pretty much like a receiving chamber. So the tendency, if you drop your blood pressure, then you do not start vasopressors right away. You have to challenge your patient with fluids. So fluids, don't worry about it because the left ventricle can squeeze it out, okay? So your patient won't get into, if you're thinking about fluid overload, unless they have an issue with the left ventricle also. So try to think that way. So right atrium receives blood from the superior vena cava and inferior vena cava, and then they go to the right atrium, right? So hemodynamically, there will be like the CBP. So if you put a central line in the patient's neck and it sits right above the superior vena cava, and now it's measuring pressure there. So we call that central venous pressure. So in the right atrium, pressure equates into same central venous pressure. And then your left atrium receives blood from the pulmonary system, from your lungs. So typically, they told me, Manny, focus on the positive, not on the negative. I think my personality is I don't filter what I feel, I just say it. So then the tendency is they take it negatively. So now I'll construct that in a more positive. I asked some of the nurses how many pulmonary veins they remember, and majority will tell me 2. And I hate to say it that they're wrong, but I just say no, it's 4. So 2 on going to the left side, 2 going into the right side of the atria, and then the blood gets into the left atria. So now you know there are 4 pulmonary veins, and these pulmonary veins don't have valves, so they will continuously dripping blood. Okay, so one of the constant function of your left atria is a tank. Okay, if it's relaxing, it's receiving blood from the lungs constantly, and if the mitral valve opens, the left atria serves as a conduit because the blood flows directly to the left ventricle. And your right ventricle receives blood from the right atria, right? So the only thing that I want you to remember, if they're putting a PA catheter in, it goes into the right atria to the right ventricle. Right ventricle doesn't like anything in there, so the tendency is they give you a right ventricular or premature ventricular contraction. So what I want you to do is look at your V1, and then you see a rhythm like this. It's a wide R wave, wide R wave in V1. And if you see that on the monitor, then you tell the doctor, oops, it's right ventricular PVC. So again, you do not see this in lead 2. If you're just watching your monitor on lead 2, it's not good. So put your monitor lead 2 and V1, then look at the V1, you see this, and you tell the doctor while they're inserting the PA catheter. And your left ventricle is actually it's squeezed, right? So I want you to remember that if your left ventricle is failing, then you have a big problem because it will have a backflow. So your AB valves are your tricuspid, your mitral. So the tricuspid is on the right side, this one, and your mitral is on the left side. Again, some nurses tend to forget this, and it's part of your job. If you are planning, or if you are an ICU nurse now, you should know where your tricuspid and mitral valve by heart. Okay, you do not guess, guys. Yeah, they were like, oh, where is it? Where is it? No, you should know it by now, right? So the reason I want you to understand it, it's because if they are giving you a problem of stenosis or regurgitation, you have a problem because hard to open doesn't close very well. Hard to open valve, stenotic valve, will create the ventricles to work harder. And if they keep working harder, the tendency is they get muscular. Okay? So hypertrophy. When you have an hypertrophic ventricle, inlet space or cavity is an issue. Then you will decrease your cardiac output. So how much fluids or volume of blood can you accommodate if you don't have space, right? So if you can accommodate normally 5 liters, so with that amount of space, that because of muscular ventricle, so you can only now accommodate 4 or 3 liters, and that's an issue. So I want you to remember stenotic valves in all tricuspid, mitral, pulmonic, and aortic is going to be the same. Regurgitation, if they don't close really well, blood will flow back. Okay, so there's a backflow. The tendency is you will create a dilating ventricles. And when you have a dilated ventricles, so the walls get really thin. And the tendency is if you put the principle of Laplace law, wherein if the radius is too high or too big, then the tension will decrease and the pressure will decrease. So what happened? If you have a decreased contraction, then you have a low cardiac output. So again, your papillary muscles, you will hold it. Okay, so there's a chordae tendineae here and the papillary muscle here. So as an advanced critical care nurse, we always look at your PA catheter. When you wedge and you see a large A and a large V wave, it looks like an M. We always look at like possibilities of this rupture of the chordae tendineae or the papillary muscle, especially if your heart becomes hypokinetic. So they're not contracting really strong, okay? So you can see that via echocardiogram. So again, I told you about the semilunar valves too, the pulmonic and your aortic valve, okay? So the cardiac cells is, I included it here because just for you to understand it better, that your myocardials are contractile machinery of the heart, and think about your action potential. Again, if you don't know what's action potential, you should have a book, and that reference book either from AACN, Core Curriculum of Critical Care Nurse, look at it and open and see. But I will supplement you some information here. However, sometimes I feel like, you cannot be putting those information in the PowerPoint slide, because PowerPoint slides should be a guide only, right? So I'm telling you guys that with the pacemaker, there is an electrical activity of the heart and there is a mechanical activity of your heart. So electrical activity is when the SA node fires, atria will contract. So that's the electrical activity, and then mechanical is when the atria contract. Okay, and that is your action potential. So there is this automaticity, excitability, and conductivity, and of course your contractility. So you go back to learning your action potential. So this is how your pacemaker works. So first is the SA node fires, and when you think about the SA node fires, as what we say is your primary pacemaker, it has an intrinsic rate of 60 to 100, and it is normally your primary pacemaker. All right, so when you say escape pacemakers, that means there are so many sites wherein your SA node fails to fire, but somebody will take over, okay? So if this is your SA node not firing because some conditions that really affect your SA node to fire and to fail, then AV node will take over. So the intrinsic rate here that you might think will be 40 to 60. So that is your intrinsic rate, 40 to 60. Okay, so that means if your SA node won't fire anymore, you still have a heart rate of 40 to 60. Lucky you if you have 60, because we're still considering that as sinus rhythm. Although you will lose your P wave. Okay, so what you probably will seeing will be junctional. Well, that's not true. Junctional is your QRS are not very wide, okay? But you lose a P wave. Your P wave is probably inverted or after the QRS, retrograde, antigrade, retrograde, okay? And then your ventricles will take over also. So there is this Purkinje fibers here, and that will give you an intrinsic rate of 20 to 40. So for those nurses who've been an ICU nurse for a while, you know that your patient is not going to die right away, right? Unless they have Brugada or they have hypertrophic cardiomyopathy, wherein boom, they will become asystole right away. Because those are some issues with blood supply into the myocardium, or your left ventricle is completely occluded. So again, guys, these are your SA node. It fires 60 to 100. Your AV junction will fire 40 to 60. Purkinje fiber will fire 20 to 40. So first is you see this first. If you lost this SA node, then takes over AV node, then your Purkinje fiber. So in the Purkinje fiber, you'll probably see like what we called what? Your oh, I forgot. All right. What we called idioventricular. Okay, so the idioventricular is, sorry. So let me just, the idioventricular is normally, okay. So let's go back, guys. I'm so sorry. So as I mentioned that Purkinje fiber, when it takes over, I lost my pen, that's why. So you will see an idioventricular like this. It looks like you don't have P wave, but your QRS are very wide and you only have about 20 to 40 rate. Okay, so that is when your Purkinje fibers takes over. Idioventricular. So when you look at this, SA node fires, it goes into the internodal pathway. So this is what the internodal pathway. And then they enter into the AV node, wherein it is a specialized myocardium or myocardial cells for designed as a slow conduction. So if I ask the nurse, why is it so important that the AV node is a slow conduction? And the answer to that is in order for the atria to contract and the ventricle will take time to fill. Okay, so that's really a good concept in there. And because I'm contracting, I'm giving you blood both right and left, right? Right atria goes to the right ventricle, left atria will go to the left ventricle. And with the AV node as being slow conduction, it gives time to, for your diastolic and systolic event to happen. And then eventually it will squeeze out into the lungs from the right ventricle and into the systemic circulation from the left ventricle. So your EKG monitoring, again, it's one of the minimum requirements that you should know that you are skillful to work in the ICU. So why do it? Because you need to monitor the heart rate, right? Because if they're 160, well, you need to do something to stop that, to slow it down, I should say. Evaluate the effect of the disease or injury, because just looking at the EKG rhythm, you can interpret if something is infarcting or ischemic event. Okay, and evaluate pacemaker function. So of course, if you lost your SA node or AV node, you know what's going on just by looking at your EKG rhythm. And then response, evaluating the response to medication. So you gave me diltiazem because I have PSVT, paroxysmal supraventricular tachycardia. Did it slow down? Okay. And you need to obtain some baseline recording, because if you're monitoring me in the ICU and all of a sudden you notice that, what's going on there? All of a sudden I converted into AFib, then you need to do something, right? Because some hospitals, they waited for a little bit until, the priority for AFib is rate control, and then after 8 hours, that's when they start heparin. But some aggressive hospital, they will look at it, and within 4 hours, you're still AFib, you did not convert, then they will start your heparin drip. I think if I'm going to ask you the goal, or why are we giving them heparin? And if you answered because AFib can actually cause stroke, then you're correct. But then I'm going to ask you again, how? So the answer is, when you look at your left atria, you have appendage in here, like a pouch, that every individual has. So what's wrong with the AFib is you lose that atrial kick, right? So that atrial kick is a 20% cardiac output, or blood, extra blood, like preload, that you can push down to the left ventricle. However, if you have AFib, those blood, about 20% will sit here. And eventually, if they're sitting there, they will start clotting, right? And you make your patient excited and mad and upset, and these clots will dislodge. And it goes to your brain. So that's why we don't want that, okay? So again, guys, if you have an AFib patient, you know that it can cause a stroke, and now you know why and how, because of that appendage. So some hospitals will give this patient Coumadin, right? But if they're young, good. But if they're old, it's too risky, because if they fall and hit their head and they will start bleeding, quality of life will get worse, because they might end up staying in the ICU and then DNR and then die after. So they put a watchman. So the watchman is like an endoscope, endovascular procedure, and they poke the left atria via septum, and then they will, like this kind of, it's like an umbrella like that. They will plug where the appendage entrance is, or point of entry, and then eventually it will granulate and seal off the appendage, and then you don't need any more heparin or Coumadin. Patients will get off Coumadin after that if there's still AFib. So that is your watchman. So what it can tell us, of course, orientation of the heart in the chest, conduction disturbances, electrical effects of the meds and electrolytes, because again here, guys, if you're hyperkalemia, there is an EKG changes. Hypokalemia, there will be like EKG changes. Usually hypokalemia, you have a U wave, and your T wave is probably get smaller or get infused with your U wave. So take a look at that. And then of course it can tell the mass of your cardiac muscles, presence of ischemic damage. Okay, so let me erase this, guys, so that you guys can see it. Okay, all right. So you see that presence of ischemic damage. How do you know that? Because if you have some ST depression, so the ST depression is, this is P, Q, R, S. So supposed to be T, it's gonna go up, but it goes down. So this is your T wave. So ST, S and T will fuse together, and that gives you like P, Q, R, S, T. So this is your ST, and that is an ischemic damage. Okay, so ST depression is ischemic damage. All right. So moving along, information about the contractile condition of the heart. So this is your lead placement. Again, if I am gonna ask you, what is lead 1? They will say, well, this is the negative, this is the positive. Yeah, you're correct. But the purpose of lead 1 is actually just like if I tell you, think about your positive as your eye, the patient's eye, or whoever is watching. Why? Because he is looking at the vector, some electrical movement of the heart. So the normal electrical movement of the heart is normally going this way, right? So depending on how big is that vector. So when you are, remember this, when you put your patient on lead 1, so what lead 1 is asking you to do is, he is actually measuring, because I told you it's looking at the velocity. So this area here is what he saw. Okay, so he's responsible to watching your heart at this level. Okay, so when you look at this, you'll probably see your R very small. Okay, so here when your lead 1, you're looking at negative to positive, right? So this is negative, this is positive. So you remember that when you're negative, you probably have about negative 2 millivolts or negative 0.2 millivolts. So what does it mean? In the EKG paper, you have 0 here. So let's go down, negative 1, negative 2, positive 1, right? Positive 1, positive 2. So your positive here will give you a 0.3 millivolts. So it measures from negative 0.2 and positive 0.3. So in your EKG paper, you know that your R wave has at least 1, 2, 3, 4, 5, right? So this is about positive 0.5. So it's not very tall, okay? Because when you look at your EKG, there's like 5 boxes in there, right? So 1, 2, 3, 4, and then it becomes 5 in one big box. Okay, and so this is 2 big box is 0.10. So 3 big boxes is 0.15. I'm talking about millivolts here. Okay, so when you think about this area here, this is your millivolts. So lead 1 is only going to give you a 0.5 millivolts. So small one, this one big box. So this, you know, the base of your EKG paper. So this is where you see probably your R wave. Okay, moving along. Another lead is lead 2. Okay, so we're talking about lead 2 now. So this is from negative, and this is where your positive is. So if the camera, so this is where your eyes, okay, so you're gonna be watching the vector here. So if the vector is coming this way or going this way, so your lead 2 will watch it within this, you know, wide range. It has a wide range that he saw the vector coming in from the start to the end point. So when you think about this, guys, so this is again negative 0.2 millivolts, but this time this is 1.0. So again, we put it in the paper, right? So this is your 0, negative, minus negative 0.1, minus negative 0.2, minus negative 0.3, plus 0.1, plus 0.2, 0.3, 0.4, 0.5, 0.6, 0.7. Let's just say this is 0.10. So you are there, right? So between this area, so you have 0.12, equivalent to 0.12. And that's like 2 big boxes plus 2 more small lines, right? So when you see your R wave, it's tall. So that's why lead 2 is the best leads to watch your R wave. That's why on your monitor, you have lead 2 in there, right? So that is the main point of why are we learning lead 2. So if you don't know this, congratulations, you know it now, okay? So lead 3 is a different lead. So hold on, guys, let me Okay, so this is your lead 1, lead 2, lead 3. So this time, your camera is, or your eyes, they are here, right? So these are your eyes watching. So this is the this is the negative here, and this is the positive here. So remember, on this area, you have positive 0.3, right? Millivolts. Well, guys, I did not make that up. So that is something that the physiologists, measured. And this is your 1.0 millivolts positive. So if the heart is here and the velocity went this area, so what lead 3 can see is this area here, right? So now this area is what the lead 3 could report to you. So he will say, oh, I see the velocity from this side, and it gives me, again guys, this is your 0, this is your, okay, so 1.1 positive, this is positive, right? Positive 2, positive 3. So let's start there. You start for positive 3, and let's say this is the 10. So 3 and 7, 10 and 3, it gives you 0.7 millivolts, right? Yep. So positive 0.7 millivolts. So if you think about 0.7 millivolts, so that's a big box and 2 small boxes, right? So that's your R wave. So therefore, what I want you to remember is Einthoven law. So Einthoven, he's the one who actually studied this. His law says that if your lead 1 combine it with your lead 3, the R wave will equivalent to lead 2. So that's just again, FYI. If you don't know this before, now you know. So your lead 1 and your lead 3, combine them together, is equivalent to the height of the R wave in lead 2. So again guys, if you don't know this before and now you know, that's the main reason why we have all these different leads. Okay, your lead 1, lead 2, lead 3. So now I tried my best to explain it to you guys the best that I could. Hopefully that you use this, because sometimes there are conditions out there that no matter what you do, no matter how you increase the capture of your EKG, like especially your R wave, they won't go big or taller. It is because of some conditions, such as, what would be that condition? If they have effusion or layers of body fats. Okay, so it's kind of hard for it to capture. So the modified chest leads is we always call it the MCL1 or the V1. It will give you a better position of your ST, especially if you're thinking like they have some ST elevation or depression. So any kind of ectopy or aberrancy, you do not use lead 2. You should use lead V1 or V3 or V6. Okay, so those are going to be your best friend. So we always say, if you're down in V6, you're dead. I mean, it's sad to say, but it's true. If you're down in V6, so that means your R wave, your S wave is really going down, then that is pretty much ectopy. So in the issue of aberrancy versus ectopy, you need to look at your V6 first. If you're up in V6, then that's something that probably is just an aberrancy with bundle branch block. Sometimes we call it SVT with bundle branch block, or is it right or left? So again, that's something that we will discuss when we get there. So some of you, I don't really try to memorize those, like they always tell me like crash under snow or chocolate close to the heart. So you do whatever that helps you to remember this, but to me, I understand the anatomy and that's where I put it. Okay, so just like what we mentioned just a few minutes ago, your white, your black is there, that's your lead one, right? And then your ground is always here. And then white, and when you look at your lead 2, it's over here. But this is pretty much your standard. So I want you guys to pay attention where to put this, because sometimes if you misplace in putting your this one, the brown one, it should go to your V1 where it is fourth intercostal space, right sternal border. So this is essential. Okay, if your CNA moved it and put it here or put it there, now you are not monitoring your patients accurately. Okay, so white in here, black in here, then your brown is on the fourth intercostal space. Okay, right sternal border. All right, so this is your fourth intercostal space. The top is the manubrium. You find the hump, and then you go from there. So 1, 2, 3, 4. That's where you put your sticky. Okay. So again, this is the V1, V2, V3, V4. Okay, this is the clavicular, mid clavicular, and then that's your V3. It's in the middle. And then you go down, this is your V6, it's supposed to be on the 5th. Okay, so this is your mid axillary, and then you just put the the 5th leads there. All right, so we already gone are the days wherein you put your right arm here on the EKG leads, right? They put it here, they put it here, and then they put it on the foot. So don't do that anymore. If this is your heart, you have 10 centimeters. So put it here, put your sticky here, 10 centimeters away from the heart, right sticky there. 10 centimeters away from the heart, then just below abdomen, right and left, so you don't have to use your arm anymore, or the leg or the shin, right? They put the leads in there, the sticky stuff. And I still see some patient, if I go to MSICU or ICU, I see the leads sticky stuff, or the sticky leads into their hand, forearm, and then into their shin. So I know that you guys are not still doing what is recommended as evidence-based practice. I think it has something to do with catching up some electrical velocity, and it will print out your EKG better than if it's too far from the heart. Okay. All right, this is your EKG paper as I mentioned a while ago. Again, guys, this is 0.04. Okay, so that's a 0.04 there, and this is 0.1 millivolts if you're gonna go up. Okay, 0.1 millivolts to things like that. So your horizontal axis is the time. Your small box is 0.04. 0.04. So the point is here, sorry. It's 0.04. So this is correct. 0.04 in a small box. So therefore, if you're thinking about your P wave, so it's supposed to be two small boxes, that makes it a 0.08. Sometimes we like it 0.1. Okay, and then your PR interval is another 0.1. So these two PR and PR interval supposed to be 0.20. So the whole, one big box here, that is your PR P and PR interval. And then of course the large box is 0.20 seconds. Okay, vertical axis, I told you, is the voltage. And it's 0.1 millivolts or 1 millimeters. And if you see a line, we call it isoelectric line. So when the machine did not sense any movement, it will become like a stealth. And that is normally your AV node, right? AV node will not, because it's a very slow conducting cell, the machine won't feel it moving. Or if the ventricle completely depolarized, so we just contract, right? And we need to rest. That moment of fully contraction is what you call the ST segment. That is another isoelectric. Okay, so just FYI. So P here, AV there, QRST, the ST there, and then T. So this is your ST segment. So the isoelectric line. The machine did not feel any movement. Okay. So electrical activity of the heart, as I've mentioned, is completely different from the mechanical. So again, your SA node fires and it goes into tissue, neighboring tissues, right? So what is happening here? If you're going to ask me, how can electricity passes from one cell to another? So one cell to another. If I am excited and I am contracting, how can I influence the next cell to contract? So this thing is what we call gap junction. Okay, gap junction. Gap junction, or also called electrical window, are part of the myocardial cells. Okay, so the more gap junctions you have, the faster the conduction. And because there are some portion of the heart here, especially in this area, wherein the myocytes are aligned very straight, right? And they have a lot of gap junctions. So when electrical activity passes, it's faster. So that's why you see like it's fast, okay? And if they are so, like the AV node, very small, and there's a lot of cells in there and less gap junction. So the gap junction are so less and very hard. They're not aligned. That's why it's a slower. Okay, what did you just learn here? The lower the number of gap junction, the slower the movement is. The more gap junctions you have, the faster the movement. And the sizes of the tissue, if they're aligned together and they're big sizes, the faster the conduction. Okay, so that's just an FYI. Again, if you don't know this before, now you know. Gap junctions. Okay, because I observed that sometimes, even in my class, I might not have time the whole, because I only have 8 hours to discuss so much, right? So that's why it's kind of hard to be very, be very complete in terms of like teaching. Tendency is to shortcut it sometimes. Okay, so we're moving on. SA node 60 to 100, AV node 40 to 60. That's so basic. And I'm giving you again this information. Okay. So what happened here is, this is what I was referring to. If I have to pick a portion of the myocardial cell and make it big, and if I say the polarization of the cells is all the, I told you about it a while ago, size of the cell, shape of the cells, and location of the cell, right? So let's discuss the direction of depolarization or stimulation. So if I have a negative sticky here and if I have a positive sticky here, this is your sticky. And we have a Galban manometer. You know those things that they use to measure electrical output? So the neutral is in the middle, right? So here, if you think that they're all negative, the cells are all negative, you will not expect any movement. So the tendency is it will stay neutral, right? Neutral. Okay. The next one is if we are all positive, just like complete depolarization. I just contracted. The cells just contracted. Then it's going to be in a neutral position. Because again, as I mentioned, the Galban manometer cannot sense any kind of movement. So these are the physiological concepts. So if you know this, good for you. If you don't know this, then still good for you because you're learning now. What if I will put electrical stimulation from the positive to the negative? What do you think is going to happen with the Galban manometer? It will go towards negative, and that will go towards the negative, so away. When you see this in the EKG rhythm, they will go away. So away means down. Okay? So what about if I am stimulating the cell from negative to positive? So this time, they're going towards the positive. So hopefully you know that if it's going to the positive, they sense it as a movement and it's going to be on a positive position. Okay? This is another concept. What if a regular tissue is a little bit thicker, right? Your atria is thick, your ventricle is thicker. So let's say this is the atria. If I'm going to stimulate the atria, I need some velocity. You need power, right? So we call that as from negative to positive, it will become on a positive position, however, with moderate velocity, because we have a strong velocity. So this is where you see this is a moderate velocity. It went up. Okay? Then this is what I was referring to, a thicker one, ventricle. If you put some electrical stimulation here, negative to positive, it will give you a positive position, but with a strong velocity, strong power or electrical power. And this is what you see on the P wave or R wave. Okay, so remember this: P wave, moderate velocity. This is higher than the V wave or taller than the P wave. So that's giving you the strong velocity. So what about this one? So this time is, I'm gonna give you an idea that if this is your negative sticky and this is your positive sticky, always remember whatever cells that contracted first will be the first to relax. Okay, so during relaxation, the action potential, this is our resting membrane when it's resting, and then this is your phase 0 when sodium channel opens, sodium channel gates opens, and there's an influx of sodium inside the cell. It will start to contract, right? And then the calcium channel gate opens, but the potassium channel gate open also, calcium in, K out, okay, and it will neutralize it, so there's an equilibrium, so no movement. However, the K continues to leave out the cell, okay, so this is where it started to repolarize. So repolarization is beyond us. It's just what your heart will do. K will leave the cell. They need to relax. So the relaxation started from the outside going in. So if I am negative here, because I'm going to relax, I told you relax is negative, right? Because the machine won't feel that, but I am normally relaxing. It's not like you forcefully relaxes me. It's my turn to relax. So negative to negative will give you a positive. So this is your T wave. So that's why they always say, but T wave is relaxation. How come that it went up as a positive position? Well, again, negative to negative is positive. So negative towards negative is positive. Okay, positive position. So your ventricular repolarization when the ventricle rests. All right, so again, guys, you have this cardiac muscle, working cells, and epithelial cells. The pumping function of the heart, some electrical stimulation. These are your gap junctions, as I've mentioned. Okay, and the more you have gap junctions, the better. And we call this functional syncytium. Okay, so these are your gap junctions, the electrical window. Okay, so I'm just giving an idea. Okay, so the thicker the cells, the more gap junctions it is, the faster conduction and velocity. The smaller the cells, the smaller gap junction or less gap junctions, the slower conduction. And of course, the more gap junctions and straight cells, the faster. Okay, so let's put it together. So SA node fires, internodal pathway goes within the atrial cells, and then it goes into the AV node. And one thing that I want you to understand, after AV node, it will go to the bundle of His. So this is your bundle of His, and then into the right Purkinje fiber, but it will stimulate the septum first. Okay, so the ventral septal depolarization, ventral septal, because it's in the septum, depolarization. So if you're new in the ICU, when you hear depolarization, contraction, repolarization, relaxation. So ventral septal depolarization, so it contracted, okay, depolarization. So it contracted, but take note, this is your positive, this is your negative, so he went towards the negative, right? So it goes down. So that's your Q wave. After the ventral septal depolarization, it's going to give you that major ventricle, the major ventricle contraction here, and that's going to give you that R wave, okay? And then it goes back to the base. So take note, these are the base of your ventricle. This is the apex, right? Because the tendency is we forget this simple anatomy here. Apex here, base here. So when they go back to the base, so we call it the basal ventricular depolarization, that is your S wave away. Okay, so that is the normal electrical conduction. As a node fires, it goes around the atrial tissue, a little moderate velocity, and then AV node quiet, and then bundle of His, and then it goes to the ventral septal depolarization. Ventral septal depolarization first, that is your Q wave, and then it goes to that ventricular major. Boom! Because you will be contracting on the left and you are contracting on the right and in the middle. So you combine these three together, it will create this major velocity. Okay? So we call it major ventricle, or the major ventricular contraction. So let's put it together. P wave, SA node fires, atrial contraction. PR, AV node conduction. So when you look at your PR segments, think about your AV node. Okay, so we want it to be 0.20, right? Above more than 0.20 is first degree AV block. Okay, and then next is your Q wave is here, ventral septal depolarization. And then your R wave is your major ventricular depolarization, so the pressure of the contraction going this way. Okay, and then your S wave, it went back to the base. It went back to the base. That is what we call basal ventricular depolarization. And then your ST is your complete ventricular depolarization. Well, again, it's isoelectric because they are all positive in there. They're just trying to relax. And then your T wave is your ventricular repolarization. All right. So PR depression is so typical in ICU, but some nurses don't pay attention. Please start looking at this. Your PR depression, if I see this, I always think of pericarditis. Okay? So it may indicate pericarditis, atrial infarction, but it's sometimes normal variant. All right. And your QRS, this is what I was referring a while ago. Look, if you have a very small compared to like the tall ones, you might have some damping effect by some effusion, right? So again, guys, or it can be the other way around. You might be seeing a very tall, R wave compared to the normal R wave, because the normal R wave we said is 0.12, right? Millivolts. If you have more than 0.12 effusion. All right. So again, guys, just to give you an idea what is a resting membrane potential, when you think about action potential, RMP, resting membrane potential, what makes it relax? Think about becoming an isoelectric negative inside the cell. When the cell is completely so negative, because the potassium is supposed to be inside the cell, it's leaking out the cell. Okay, so that makes it really negative. So there is this what we call an RNA messenger. There's an enzymes inside the cell that gives you the RNA messenger, and that will trigger the ATPases. Oh my God! So the sodium channel, sodium potassium ATPases. If you never heard it before, then now you know it now. So what this means, you have the inside the cell, it will give you 3 of sodium out, so 3, and 2 of potassium in. All right, don't blame me, I did not make this up. This has been in the literature since I became a nurse. So I learned it 30 years ago, and I'm just sharing it with you guys. So when you hear that sodium potassium ATPases, that's what the normal function, or what the cell will do. Even in your kidneys, they do this a lot in there. There's an exchange. So in the cardiac cells, they like to have a sodium potassium ATPases. Think about this all the time. Sodium will stay outside, 3 sodium, 2K will stay inside. Okay. And there is an electronegative inside the membrane. So at this time, it will give you a negative 5 millivolts. And then it will continue an electrochemical gradient. That means exchanges of some electrolytes, cations. Concentration of gradient will become less inside the cell. But then the sodium really wanted to go back. That's what he likes. But because the potassium would love to escape, and that is they can escape, and what we call leaky potassium gate, the potassium gate will become leaky, and they still continue to get out of that cell until it become a negative 60 millivolts inside the cell. Electrical gradient in the cell will definitely become electrically negative to the point wherein it's reaching some negative 80 millivolts, and then sodium or potassium will continue to escape, and it will become negative 90 millivolts. So that is your resting membrane potential. They will become so negative to the point that inside the cell compared outside the cell is so negative. Okay, so this is your resting membrane potential. Who's responsible for your heart to relax? Your potassium. He doesn't want to stay inside. All right, so your action potential, as I've mentioned, starts with resting membrane potential, right? And again, review if the inside the cell become isoelectric negative. And then eventually, during that leaky potassium, sodium will start to go back in. They'll find their way to go back in. And if that's gonna happen, it makes the action potential will reach its threshold. So what is the threshold? Negative 70. When you reach a threshold, it's just like those one-way valve that will open because you reach that water level, and if that 70 millivolts reach that threshold, it started to open some sodium channels. So this is your sodium channel gate. So the activation gates open, and an influx of sodium inside the cell. When you have sodium inside the cell, it reaches to the point that your millivolts is going to 0, and then positive 10, positive 20, right? So if you have a 20, it reaches this is your phase 1. So this is phase 0. This is your phase 1, wherein some chloride will go in and it slows down the sodium influx. And then phase 2, so this is your phase 2, the calcium channel will open. And then your potassium channel also will open. So calcium will go in inside the cell, potassium will leave the cell. So we call it equalizes, and that's what we call equilibrium. So it stays the same. It plateaued. And then phase 3, potassium continue to leave the cell, out of the cell. That's when you are now your resting membrane potential will start, because as I've mentioned a while ago. Okay, so you have to remember this or understand it, because when you're giving your medication, this is your sodium channel blockers like your lidocaine, right, procainamide. This is how what they're doing is they're closing it. So sodium channel blockers, so they're blocking it. And then your phase 2 calcium channel blockers like your diltiazem, calcium channel blockers, okay? Because the more calcium you have inside the cell, the more they get excited and they will contract more, faster. They have a lot of energy, right? So that's what you do, diltiazem. And then here is your amiodarone here. So phase 3 is where your amiodarone. Why? Because this is the most vulnerable. We call it the absolute refractory period, or relative refractory period. So if you heard relative refractory period before, good for you. What does it mean is if I have a very strong stimulation here, right? Strong stimulation, it will give you your patient R on T phenomenon. R on T phenomenon. So VTAC, VFib, Torsades, you know, you don't want that, right? So we give them amiodarone there. All right. So this is how your SA node will look like. Okay. Take note. Your SA node action potential is a calcium dependent. Calcium dependent. So the higher the number of calcium, the more SA node gets excited. Same way with your AV node. AV node is also a calcium dependent. So the only thing that is a sodium dependent are the rest. So if you know that and if you remember that, you know the action potential. Okay, so SA node, AV node are calcium dependent. And then your atria or ventricle, they're sodium dependent. Okay. All right, this is your action potential. I just expounded it. So if your activation gate is open, so there's only one way out. But if they're both open, they will open on top and open down. So two gates are open. Okay, so you can only reach this activation gate if you have reached the threshold. Again, this is a action potential of the SA node. I mentioned a while ago that your sodium will go out, but calcium try to go in. Okay, so they're escaping sodium out. The sodium starts to leaks out. Okay, so they're not really active. That's why your SA node don't need sodium. They need calcium. Okay, so this is just a so what does it mean? Your threshold will start at the 60 millivolts compared to negative 90, right? So when you think about negative 90 millivolts, this is stronger than starting at negative 60. Okay, so that's just a note, take note. So your calcium goes in, and your potassium goes out. So they're really, so this is your atria. Again, the atria is the sodium channel opens just like the normal action potential, but they have a shorter plateau. So that's why they can give you more than 60. So some of your autonomic nervous system plus electrical, cardiac electrical, and mechanical activities of the heart. So this is just to give you an idea. There's sympathetic stimulation, such as your coronary nerves. And you have your circulating epinephrine. And that's going to give you the beta 1. Beta 1 adrenergic. So beta 1, you have 1 heart. Beta 2, you have 2 lungs. Okay, so just FYI. So again, your SA node is included into the beta 1, your atrial contractile myocardium, your AV node, and your Purkinje fiber. So they are in the beta 1. And also some ventricular myocardium. So your parasympathetic, so again guys, if you stimulate your sympathetic and you inhibit your parasympathetic, your heart rate goes up. So let's see what parasympathetic is doing. Parasympathetic are your vagal nerve, right? Vagi on the right and your vagi on the left. And what they do, they will give you the acetylcholine M2 muscarinic receptor. So they have the acetylcholine M2 muscarinic receptor, and that gives your SA node, stimulate your SA node. Well, your SA node has parasympathetic, and your AV node has parasympathetic too. So that means they can go faster, they can go slower. Okay, your ventricular contraction don't have any parasympathetic. So your beta 1 adrenaline stimulation. So sometimes the nurses would be like, oh, why is his heart rate so fast now? Well, you made him upset. Joke. Or somebody made him upset. So some of our patients are not really happy. Or sometimes people will make them unhappy, especially if they've been waiting for the doctor, they want to go home, or they just receive a phone call from family, things like that. So what happened? There's an epinephrine release into the system. You triggered some myocardial cells to get excited. You stimulate the G protein. There's a beta and gamma going on in there that will give you that low energy molecule. We call it the GDP. And your GTP will convert into the high energy molecules, and then eventually give you that adrenaline cycling, your ATP, right? And then your cyclic C-amp, and open your protein kinase A will eventually unlock those calcium channel gate. They will have a calcium influx inside the cell. They make them so excited, and this is what happened to your SA node. Okay, it will fire faster. So calcium we don't like calcium inside the cell. So calcium channel blockers, right? So arrhythmias. I think this video is more on the EKG, so that's good. So sometimes in the ICU, we always say, well, what is the definition of sinus rhythm normal, right? So we would like for you to understand that there is that verbiage that everybody needs to agree. So 60 to 100 is what we say normal range. And that they should have a normal conduction pathway, or it originates in the SA node, and a normal conduction pathway, right? So you have P, PR, Q, R, S, ST, T wave. And there's a normal velocity. They're not too big or too small. So that is your sinus rhythm. 101 to 150, we call them simple tachyarrhythmia, okay, sinus tach. And 151 to 250, we call them paroxysmal tachyarrhythmia. So again, if they're more than 250, or let's say 157, 250, paroxysmal tachyarrhythmia. If they're 251 to 350, they are fluttery. A flutter, V flutter, ventricular flutter. And then if more than that, 150 to 200, 201 to 250, 251 to 350 is fibrillation. Okay? So, again, 100 to 150, 101, simple, 151 to 200, paroxysmal, 201 to 250, flutter, 251 to 350, fibrillation. Here, if you have let's say 51 to 59, mild Brady arrhythmia. If you have a heart rate of let's say 31 to 40, moderate Brady arrhythmia. 0 to 20, severe Brady arrhythmia. So the slower the heart rate, the more severe the case. So what are the mechanism of cardiac arrhythmia? Again, if you understand this, you know what's going on. If you see your patient having a PSVT, what's causing that? Or they give you like heart rate of like 300, oh my god, 200. So you have your increased automaticity. You have the triggered automaticity. You have reentry. Okay, so these are the issues. Increased automaticity, triggered automaticity. So the word triggered, you triggered it. Okay, increase, that means by any means, I don't know what factors created that to go up. And then reentry is probably something is not right in the AV node, right? Or in the fibrous ring. So there is this, in the middle of the heart, you have that fibrous tissue in there from the atria and the ventricle. And the only window to get into the ventricle is the AV node, right? So this is your AV node, is the gate to go to the ventricle. With reentry, we might have some issues on this area, on this area, on this area. So in that boundary, okay? So just keep that in mind. So increased automaticity is, again, we talk about your action potential here. So look at that, you trigger it so early because there are some calcium in, sodium and calcium going in, and your potassium is leaving. Okay, so that's increasing your automaticity. So the doctor's order, either they're giving you diltiazem, metoprolol, those kind of things, right? Beta blockade. And your triggered automaticity is, again, your action potential into the atria, ventricle. So what you're asking here is there might be an early or a late. So if you have ischemic cells, injured cells, and increased catecholamines, so what's going to happen is, look at this, guys. So this is your action potential. Instead of resting, it went up again. Okay, so that's not good. So these are the things that you see. And if you have this, especially if the ischemic cells or injured cells, the tendency is that calcium channel gate is blocked. So calcium cannot go up, but they come in, right? So this is your calcium. They kept flooding the cell. Inside the cell, they have more calcium and they cannot leave the cell, and that creates triggered automaticity. Reentry, there's some situation wherein you might have some bundle of Kent. So the bundle of Kent, so just say you have an obstruction here. So that's what happened. See, it will go around the obstruction or any kind of like injury in there. They'll go around it and then they don't know how to find their way down. So that's why they kept triggering that, and that is your paroxysmal supraventricular tachycardia. So if this is the problem, you see your R as narrow. Okay, they're narrow, but you don't probably see a P wave. Okay, but it's really fast. It's gonna give you really fast. So this is your supraventricular tachycardia. So physiological sinus arrhythmia, again, when you think about your sinus arrhythmia, this is something that the nurses are, when they do the EKG test, they get it wrong because they always think it is a, let's just say, they always think that it is a PAC. So this is probably regular, and then it tends to slow down, right? So, and then this is another set. So what happened, think about this, guys. This is probably during inhalation, and this is probably during exhalation. So let's look at it. So your brain stem it has connected to the vagal nerve into the SA node, right? So if you inhale during inspiratory, you are stopping the vagal nerve. So therefore, your heart rate goes up. If you exhale, you're telling the vagal nerve to work. And so your heart rate will slows down. So during expiration, you see your heart rate slowing down. Okay? So because of that vagal nerve. So that's what we call sinus arrhythmia. So again, during inspiration, okay, this is when you're taking a deep breath, you're removing the vagal nerve, and when you exhale, then the vagal nerve is working again. Okay, so that is your sinus arrhythmia. Alright, so look at this, guys. So when you think about matching them, that's probably during inspiration, it's faster. And when you think about their distance, this is probably during expiration, they're slower. So dysrhythmias originating in the SA node. SA node is here. So look at your P wave, right? So look at your P wave. Why is my P wave getting flatter? You know, round, round, and then flat, and then disappeared, and then disappeared, and then kind of there is again. So different shapes, right? But 1, 2, 3, 4, 5, 6. This is about 70, right? Because there's one more here. So this is a wandering atrial pacemaker. So again, look at your P wave. We talk about your SA node as your P wave, but it's a different shape. That means they are from here, from here. So the sources of your P wave or your SA node fires in a different areas into the atria. So you're a wandering atrial pacemaker. However, the faster version of that, this is more than 100. You call it multifocal atrial tachycardia because your P wave, look at your P wave here, it's a different shapes. So it's a different shapes P wave, but it's faster. So that's why, look at it again, you get confused, right? Because you're trying to match them, and they're so irregular. That's not how it is the definition of that. There is a P wave, so don't worry about it, but it's just different shape. So they want you to call them multifocal atrial tachycardia or MAT. So there is a multifocal atrial tachycardia here. Okay. All right, guys. So your PAC, so matching, you get a piece of paper and then boom. Oh, it's still good, but then this one is your PAC. But I call it PAC because there's a P wave. Because they might have some like this again, but no P wave, and that is PJC, premature junctional. So that's the difference between PJC and PAC, okay? Because you have your P wave, your SA node still firing. So this is your Re-Entrant Tachycardia, as we said, okay? Look at that. So this is a one-way block because they look the same. They're just fast. The A flutter, so you see the fluttery in there, the F wave. A fib, okay, so look at that, it's fibrillating. SVT, so SVT is because it's more than 150 and they're narrow QRSs. You don't see your P wave, it's probably there embedded, very small, but your rate is more than 150. So the WPW is, now you see a delta wave here. So what is that? Well, during AV nodal, right? So if this is your AV node, so the flow of electrical current should go around it and very slow, right? Because AV node is a slow conducting cell. However, with the bundle of cant into the middle of the heart, I told you, there's this shortcut. So stimulation passes into this shortcut and it's faster. So you lose that PR segment, right? So that's why the P and then the delta wave, it's faster. So that is why it's entering into the bundle of cant. Some nurses said, I never heard about that. Well, you're not reading a lot, or you're not updating yourself. So thank you for watching. Now you know, right? Because it's really scary if the nurses don't know. Because you guys are the eyes, the ears of the patients. You are there 24/7. And the doctors are only there 5 minutes, 15 minutes. Then so if you don't know what you're looking for, how can you call them, right? So that's why I ask you, please, if you are really be a part of critical care, you should upgrade your knowledge. And you can only upgrade your knowledge if you read, you go to seminars, you spend time watching videos like this. And I know it's long, but it will help you. Alright, this is your premature junctional. I told you about the junctional because if you can spot it here, look. So this is probably, and I don't, so the junctional, either your P will inverted or after the QRS. So the P is antigrade or retrograde. So you might see an inverted P wave or a P wave after the QRS. And that is your junctional, okay? Considering the PAC. The PAC, you have a prominent P wave, but you don't have it here, right? So let me erase this so that you can see. See, you don't see it there, right? It's flat. It's kind of like flat. But if you see like a hump in there or a depression, then that is still junctional. So the junctional escape rhythm is giving you this, guys, 40 to 60. So you have this 40 to 60 beats per minute, and it is usually regular, sometimes irregular. Your P wave supposed to be inverted or absent. It may appear before or after QRS. I just mentioned that. So this one. Okay. Junctional escape rhythm. PJC, premature junctional complexes. Okay. So the premature junctional, again, this one. Alright, accelerated junctional, if your rate is more than the 60, 40 to 60, right? So 1, 2, 3, 4, 5, 6, 70. But then you don't have P wave in there. So there's no prominent P wave. But your QRS is so narrow, slim. So that's the one of the things that I always look for. Atria regular, ventricle regular. QRS, inverted or absent P wave. And your QRS will all have look-alike and less than 0.12. So that's your junctional, accelerated junctional. So the junctional tachycardia, we just mentioned that, right? Accelerated junctional rhythm and junctional tachycardia is the same. It's just more than 100 to 180. Okay, and your P wave is after the QRSs. So there's no P wave in there, but the P wave is after the QRSs, and then the T wave there. Okay, so dysrhythmias originating in the ventricles are your PVCs, right? So you have the bigeminy, trigeminy. So this is your PVCs, ventricular bigeminy, because you have one and then like normal sinus, and then another PVC, then normal sinus, and then another PVC. but they're look alike, right? So if they don't look alike, kind of like they don't really look alike here, because except for this, because this one and this one and this one are unipolar, but this one is not, so they become a multifocal, right? So again, these are multifocal because they have there, then you have the other one. So check your electrolytes, magnesium and potassium. So one thing that I always ask, if you have a low magnesium and low potassium, which one, if you get an order to replace them, let's say you have 2 grams mag, and then you have K is 60 mag. So which one are you gonna give first? If your answer is K, you're wrong. If your answer is mag, you're correct. Because one of the side effects of hypomagnesemia is refractory hypokalemia. So therefore, no matter how much potassium you're giving, if the magnesium is not corrected, he won't keep it. It won't go to the cell, right? So that's why work smart, don't work hard. So if you know this now, good for you. Use it. Give magnesium first, not potassium. So this is your sinus rhythm with your unifocal PVCs and multifocal, and I mentioned that a while ago. Look at your idioventricular. So sometimes you see it like this, like twisting, but the thing is your QRSs is so wide. Okay, they're more than 0.12, and that is going to tell you about idioventricular. And your rhythm rate is 20 to 40. So 1, 2, 3, 4. So 40, and no P wave, very erratic. I don't even know what's going on here. It's probably the placement, but if you have this is now your accelerated because it's more than 40. 1, 2, 3, 4, 5, 6. But look, it's more than 0.12. No P wave, no, nothing in there. So that is your accelerated idioventricular. VTAC. So if you don't have a pulse, what do? Yes, defibrillate. If you have a pulse, look at your patient. We always say, if the patient is okay, give them pharmacy. What? Well, give them some medication, amiodarone, right? If they said, nurse, I don't feel well, I'm dizzy, I'm going to pass out, well, cardiovert, right? Cardiovert. And if you lose the pulse, defibrillate. So, torsade, so the twisting. So twisting, okay. So some nurses who took my test, they don't know, they think this is VTAC. No, it's the twisting. So give them magnesium, okay? This is now triggering your R1T phenomenon. So if you still remember what part of the action potential that could trigger the R1T phenomenon, good for you, keep that. And that is towards the relative refractory period. So this is the relative refractory period when the potassium is leaving the cell. VFib, nothing you can do, right? Defibrillate. Defibrillate, CPR. So first degree block. So this is what we always remember. The AV node, SA node fires, it goes to the AV node, but the AV node is giving, it should give you less than 0.20, right? Or 0.20 seconds. So what happened with your first degree AV block is if SA node fires, AV node fires slower. So it's more than 0.20. Do you worry? Not really. Just watch your patient vital signs and mentation. And then the second degree type 1, Mobitz 1. SA node fires, it will continue to fire because it's not ill, but the AB node is the one who is ill. So at first it gives you probably okay sinus, and it fires the SA node, and now it's more than 0.20. So it's probably 0.24. So if your PR interval is 22, then 26, and then 0.30, right? And then it dropped. So you have more P's than QRS. So longer, then drop. Okay, so that is your Mobitz type 1. Mobitz type 2, on the other hand, is the SA node will fire and the ventricle will either fire, or AV node will either fire or not. So again, there's no such thing as longer with the PR interval. That's not the case for Mobitz 2. SA node will fire, either AV node will fire or not. SA node will fire again, AV node will fire or not. SA node will fire again, AV node fired at long last, right? So you see P, then P, Q, R, S. So you have more P's than QRS, but there's no issue of PR interval. So this is your Mobitz 2. So be very careful because it can also be 2-to-1 conduction block, okay? Because it can be tricky. Just like what I give you here, 2-to-1 block. Or, so that's something that I want you to pay attention, because it can either be like the regular Mobitz 2 or 2-to-1 block. So look at your strips, your rhythm. So if you see P, Q, R, S, then P, right? Then P, and then P, Q, R, S. So you have more P's, and then, but you only saw this once because it went back again like that, and then it went back again. So this is probably very irregular up to 2-to-1, but you can tell that this is Mobitz 2, right? So again, the difference between the two, this is PR segment, longer drop, longer drop. Here it doesn't have that. P drop, P drop, PR, PQRS, good. You know what I mean? So okay, good. Then of course your third degree, they don't follow each other. So this is just an idea. Okay, so you look at that, it dropped there. So you look at this PR longer, drop. Mobitz 1. Okay, look at the PR, no issue, right? But it dropped, Mobitz 2. Alright. So again guys, this is a 12-lead EKG advanced concept. When you have an EKG, you're doing EKG, you always say, what is the rate? What is the rhythm? What is the axis? What is the evidence of hypertrophy? Is there any evidence of ischemia or infarction? If you are been a nurse for a while and you know this, good. But if you're a new nurse, you probably struggle in the beginning, unless you keep this material with you, take a picture of it, and then or write it somewhere. So it will guide your practice. You always look for the rate. Again, if it's more than 100, sinus stack, right? So things like that. So when you look at this, guys, this is a 12-lead EKG, right? So what I normally do, I look at here 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. And then the rate is 12 times 6. Let's see. 12 times 6. 72 sinus rhythm, right? Well, let's see. You have a P wave there, you have a P wave there, so it's sinus rhythm. And then the other question is, what is the axis? So the axis and axis deviation is you look for your V1 and your F. So the normal is you're up in 1 and you should be up in AVF, and that is normal. Okay. However, if you are, think about this, guys. So this is your axis, right? This is 1. This is 2, right? And this is AVF. And this is your 3. And this is your AVL. Okay? So when you think about this, going down here is towards the positive. Going away is go towards the negative. Okay, so that means if you're up in AVR, positive. Down in AVR is negative. Up in 1 is positive. Down in 1 is negative. So if you're down in 1, right? So this is your 1. If you're down, you're going this way, right? Because this is your negative. This is your positive. So you're going towards right. Right? This is going to left. So let's do that. Up, down, left axis. So you're towards here. 1 is up, ABF is up, normal. Lead 1 is down, ABF is up, right axis. Okay, so again, well, Manny, why is that right axis? This is 1, right? This is positive. This is negative. It's here. So this is right axis. Because he was negative in 1, right? And he is positive in AVF. So this area here. He's on this, he's getting this pi. Okay, down, because why? There's 3 in there, there's 4 in there, so whichever the highest, that's going down. And your AVF, again, look, shorter, longer, intermediate. So now what's intermediate? You are on this side. Okay, normal, right, left. All right. Ooh, we have a lot of things to do, right? So guys, this is the left axis that I just mentioned. If you're going towards LAD, left axis deviation, left ventricular hypertrophy, left anterior hemiblock, inferior MI. So this is your normal axis here. And if you're on the right axis, you're deviating towards the right axis, and that is your right ventricular hypertrophy, pulmonary embolism, left posterior hemiblock, lateral MI, WPW, your Parkinson-White, right, syndrome, and then dextrocardia, your heart is not facing the left, it's facing the right, and mechanical shift of the heart to a more vertical, such as emphysema. Intermediate are VTAC, VFib, ventricular pacemaker, multiple infarctions, hyperkalemia, and severe right ventricular hypertrophy, such as core pulmonary diseases. Alright, so this is just a calculating the QRS axis. Okay, so he says there 1 is 8, positive 8. So 1, 2, 3, 4, 5, 6, 7, 8. And then here is positive 14. So count down 1, 2, 3, 4. Okay, then 14. Then you connect them. they are on this area. Same way. Okay, same way, guys. All right, so this is just to give you a overview of what is that axis deviation and what makes them going that way. It's that velocity, electrical current. Okay, so that's why it's essential that you understand your 1 and your AVF in terms of looking for deviation. 1 and AVF, 1 and AVF. Okay, so again, hypertrophy. So the third criteria is hypertrophy. You're looking for the left ventricle hypertrophy. You're looking for the right ventricle hypertrophy. So what did we do? Getting the rate, right? Fast, slow, normal. Then we look at the deviation or axis deviation. So you look for 1 and AVF. And then now hypertrophy. This is when you're doing your 12-lead EKG. So the limb leads, your V1 to V6 or V5, yeah, V6, is what's going to give you the voltage criteria. So there's a lot of rules. So the first rule I'm going to ask you is look at your V1. It says here, look at your V1, right? So R wave in 1, lead 1, S wave in lead 3. R wave in lead 1 and S wave in lead 3. So those are your limb leads. Okay, but if you're gonna look at the R wave into the precordial, look at your V4, and they should be 26. So your V4 is here. Okay, so going up, and then look at your R wave in V5. Okay, you will add that with the S wave in V1. So either 5 or V6 here, either or, it doesn't make, like, don't combine them because it says or. So let's say use V5. So there's 7 here, and your S wave on V1, S wave, this is the R, right? Okay, this is your R, this is your S, this is your T. So R, S, so this is what we want, right? So there's 12. 12 plus 7 is 19. So you only have 19. But if you're more than 35, you have a left ventricular hypertrophy. But we don't have that. So, okay, so your V1 is your S wave, your V5 is your R wave. You combine them together. If you have more than 35, you've met the criteria of left ventricular hypertrophy. What about right ventricular? So the right ventricular, again, you look for the dominant R wave in V1, dominant R wave. Oh, look at that. See, this one is going up. So if you have more than 7, so again, this is 5. Oh yeah, it's more than 7 because this is 12, right? So 0.12 millivolts. Then look at your S wave. So it's the opposite this time. S wave here on V5. Do you have more than 7 going down? So yes, okay, well, this is 2, this is 5, this is about 4, so 9, 10, 11, yes. So you combine them together, then if you met this, you're just gonna check, then you met the criteria of right ventricular hypertrophy. Then of course your MIs, your ST elevation, your ST depression here. So how do you know if it's septal? So this is V1, V2. That is your septal MI. How do you know if it's lateral? So 1, AVL, right? Sorry. And then 5, 6. So this is your lateral MI. 1, AVL, V5, V6, lateral. What about anterior? Anterior is your 4, your 3 here, So that is your V3, V4 is your anterior. What about your inferior? Inferior is 2, 3, and then your AVF. 2, 3, AVF. Look for the ST elevation, ST depression here. Alright, so that is your MIs. Okay, so again guys, this is your ST depression. Okay, that's the J point. So did you see that? Upsloping, horizontals, and downsloping. Upsloping, horizontal, and downsloping. Then of course, this is your RIP. Alright, so this is just an ST segment. Okay, talk about it. So bundle branch block, I just normally look for RSR. RSR is the rabbit ear. If you look at your V1, where do you see your rabbit ear? Is it in V1 or your V6? Okay, so look at your V1 and V6. If you see V1 rabbit ear, where is your V1? It's on the right side, right? And where's your V6? It's on the left side. So V1, right bundle branch block. You see the rabbit ear here? Right bundle branch block. Where do you see the rabbit ear? V6, left bundle branch block. Okay, so that's your rabbit ear, your RSR. We call it RSR. All right, RSR. Left bundle, RSR. All right, and then you have your pacemaker. So the pacemaker, we ask that you know what's the pacing rate. You put the pacemaker rate to like 80, for example. You should feel a pulse with that. 80, it should also be an 80. So pacemaker is a little bit tricky because there are a lot of rules in here. And if you're a nurse who's looking for that, we'll probably make another video about pacemaker. But just to give you an idea, there is a threshold that you might hear is the lowest energy that will cause the myocardial cell to contract. And we always check for the thresholds. So stimulation threshold, you at least set the rate 10 below or above the patient intrinsic rate. And you decrease the output by slowly turning the output counterclockwise until you lost the EKG for capture. Okay, and then you increase the output and slowly turning the output clockwise, and the EKG will consistently showing you the capture. When you say capture, guys, like this, P, there is that spacer spike before your P. If you're sensing and pacing atria, and there's a spike and then the QRS on the ventricle. Okay, so the output will be 2 to 3 times greater than the stimulation. So if you did this and you got 100% capture at 10 millivolts, you give this patient 2 times, so 20. And this is to provide a 2-to-1 safety margin. Okay, so again, stimulation of the threshold. Threshold stimulation, you're stimulating, so you need to double it once you get a consistent capture. Sensing, you're sensing, right? So what you do is, this is what the pacemaker is seeing, your own intrinsic heart rate. So how do you do the sensing threshold? So your heart rate, your machine should be below the patient. So 10 below. If my heart rate is 80, give me 70 on the machine, on the pacemaker. And then you go slow. You set your output to 0.1 because you gotta start low and then go up. And decrease your sensitivity by turning menu parameter. Okay, so when you increase the sensitivity, you are slowly turning the menu parameter clockwise until the sense indicator flashes. This is the blue light. So the pace indicator stopped flashing. So when it's sensing it, the blue, you should not be seeing the green light, because the blue light is sensing, oh, I saw your own rhythm, so I'm not going to pace, okay? And when you do that, that is your sensing threshold. Let's just say you saw the blue light at 0.5 millivolts, right? Cut that into half. So 2.5 is your final setting. 0.5 is your sensing threshold. All right, so that is your sensing threshold. So troubleshooting again, failure to capture when you have a loose connection, lead wire fracture, dislodgement. Okay, just check. Call the doctor. They'll do it for you. Because nothing we can do here, because we can't manipulate. They're the ones who's, you know. So just to give you an idea, how does it look like, right? So you will capture and you will either you lost it then. Failure to sense, again guys, either you're oversensing or you're undersensing. So when you're oversensing, you are under pace. If you're undersensing, you are overpacing. So some of the causes are skeletal contraction, muscle contraction, decreased sensitivity. If you have undersensing, tissue ischemia, electrolyte imbalance, right? Defect or dead battery. So what is a serious complication? Lead dislodgement or disconnection, bleeding, tamponade, thrombophlebitis, air embolism, catheter knotting. It's kind of hard to remove that if they get knot. And pneumothorax infection, okay? Perforation, asystole. Alright guys, well I thank you, and I know there's a lot of information here, but I'm hoping that this helped you guys. Thank you.